Hello everyone. Now I'll discuss question of oncology. So we are getting a 58-year-old man brought to emergency department after witness a tonic-clonic seizure. The patient was at work when he suddenly collapsed and convulsed for approximately a minute. His co-workers say that patient was confused immediately afterward. However, he is now awake and cooperative. He has been having headache for last several weeks and has never before had a seizure. He has no prior medical problem and takes no medication. Patient is a former smoker with a 45 year of history. Occasionally drinks alcohol and doesn't use any illicit drugs. Patient never travel outside the country. The patient temperature is normal. BP is normal. Okay. Cardiopulmonary auscultation is normal. No masses are present on abdominal examination. Cranial nerve are intact. No muscle weakness. No sensory. MRI of the brain reveals several discrete circumscribed lesion at the junction of grey and white matter. This is very, very important line. In fact, this is the crux of the whole question. It's a golden line to remember. It has a special meaning. I'll talk a little later on. With surrounding edema, HIV test is negative. Most likely cause of the problem is what? Well, the answer is metastatic lung cancer. Well, why this answer? First of all, patient has a very long history and a very heavy smoking, 45 years. And multiple lesions are in the brain as shown by the MRI, and they really indicate that patient has metastatic lung disease. Now, why you are thinking on those lines? First of all, history of smoking, as I told you. In fact, it's the most common malignancy to spread to the brain. So, other way around, we can ask, what's the most common primary site from which secondaries come to the brain? The answer is lung cancer. But again, I have one more question for you. Stop the video, write down the answer. Now, we know there are so many types of lung cancer that we have, which can. Which type of lung cancer is most common to spread to their brain? Write down the answer in your copy. Answer is non-small cell lung cancer. It's the most common lesion to go to the brain. Of course, others can grow, but it is most likely to go. Well, neoplastic cells, they travel through the vasculature. Okay, and they lodge in the small caliber vessel at the gray and white matter junction. And that's why I told you, secondaries, they usually go in the gray and white matter junction. The point what I mentioned in the question also, there's a golden line to remember, don't forget it. I have one more question for you. Stop the video, write down the answer. Now, it is said that these cancer cells which have in the lung, they have gone to brain via vasculature. Now, tell me which cancer goes to the brain via lymphatics? Which cancer, which primary site goes to the brain via lymphatics? Stop the video, write down the answer. Well, the answer is none. Why none? Because brain don't have lymphatics. Very simple. Okay. So whatever has to go, it has to go via vasculature only. Well, multiple lesions are there, and they may form, and they may make a mass. They can make a mass together. They may coalesce, and they can cause mass effect from tumor growth and edema. Although pulmonary symptoms arise in majority patients, but at times, like in this patient, they don't have much of the lungs features. Uncommonly, in around 20 to 30% cases, patient may manifest with first time with metastatic brain cancer. That means they don't have much of the lung problem. At this point, this is a very, very important point. When we say the answer is metastatic lung cancer, okay, so everybody think that there's no lung problem, then how can you think about? But remember, Again, a golden line to remember, 30% of the patient may just manifest with metastatic brain cancer. Now they will have a headache, focal deficit, cognitive changes, seizure, like in this patient. Okay, and remember, these headache occur due to raised ICP, any space occupying lesion, what we call as SOL, can cause raised ICP, that's causing headache. That's why the patient also had a headache for a long time. And now they have a seizure problem of the patient. That's why he was brought to the hospital. Well, MRI of the brain with contrast usually reveals multiple well-circumscribed lesions. Vasogenic edema at gray and white matter junction. So you can see classically, you can see this well-circumscribed lesion are seen. Now, in this patient can have vasogenic edema also. Okay. And now I have one more question for you. What is the drug of choice to reduce vasogenic edema, especially in this patient where like this well-circumscribed lesion are nearby, edema is also there. Now you want to reduce the edema in this particular patient. Which is the drug of choice? Stop the video, write down the answer. Answer is steroids are the best given to reduce swelling in this particular case. Usually injection dexamethasone is given. Okay. Now primary tumor must be identified. Usually with chest X-ray or CT scan is a better option, definitely much better visibility. And biopsy for definite diagnosis. Now let's look into other option. Can it be a case of cerebral toxoplasmosis? No, because it is seen in HIV cases. In our other case, in our patient, HIV is negative. And how they do manifest fever, headache, altered mental status, seizure, almost same finding. That's what we get in secondary also. And but fever is additional finding that we are getting here. And now imaging typically reveals multiple ring enhancing lesion, and patient has a HIV negative, so no fever. So hence this is very, very unlikely diagnosis. Now look into this. You are getting lesion of, we are getting lesion for toxoplasmosis. Okay. What about glioblastoma multiforme? It's a brain tumor. It's a grade 4 astrocytoma. It's a highly malignant tumor. Highly. And it definitely causes headache and seizure because it's a very rapidly growing tumor. Single lesion are the norm. Something unique that is usually single, usually not multiple. In our case, we are getting multiple lesion. So automatically it rules out. Okay, and of course, in adults, metastatic lesion are much more common. But to remind you, in children, primary brain tumor are more common than the secondaries. But in adults, secondary brain tumor are more common than the primary brain tumor. You can see glioblastoma multiforme. Okay, this was okay. Now, primary CNS lymphoma is an uncommon form of non-Hodgkin lymphoma. Primarily seen in patients of HIV and other form of any reason of immunosuppressive. As I just told you, toxoplasmosis occur in HIV patient or immunosuppressed. Same thing here, this also HIV or immunosuppressed, but our patient is typically, we already investigated, it's not a case of HIV. And moreover, CNS lymphoma, they tend to occur periventricular, not gray and white matter junction. There's a additional point that differentiates from secondaries. Now you can see this the ventricle, and we are getting near this, we are getting CNS lymphomas. What about neurocystic sarcosis? Is caused by poke tapeworm, Tinea solium, and other often present with new onset seizures. Typically, it reveals cysts at various stages of development, and it may have even calcified granulomas may form in these patients. You can see typical cystic lesion are there. Golden line to remember: lung cancer is the most common neoplasm to metastasize to the brain, and it may present with headache, focal deficit, and cognitive changes or seizures. Secondaries: this is true for any secondaries. MRI of the brain typically reveals multiple well-circumscribed lesions with vagogenic edema at gray and white matter. This is the most important line to diagnose secondaries in the brain. Is the out of this golden line, this is the most important line. Don't forget. Thank you very much.